Yes, hello and welcome. My name is Prof Merseburger and I'm sitting here in Baveno, Italy with my dear colleague Professor Prof Danesi from Pisa, Italy. We are here at the prostate cancer current treatment practice meeting to really going into practical aspects on how to treat this deadly disease. And I'm very delighted to have you here as an expert. Maybe you can find some words of your background. What is your daily job?
Yes, okay. Thank you, Axel. Thank you so much for this discussion. My job is clinical pharmacology, so my daily job is to help clinicians in the definition of the potential drug interactions, and this job is just to avoid the risk of toxicity associated with multi-drug treatment, which is very common in the daily practice. Drug interactions are very common because on the average, patients can take up to 7 different drugs, and for these reasons, there are potential interaction at the liver function and also renal function. So the problem is viable and should be addressed with professional relevance.
Romano, thank you. This is what we heavily discussed the last couple of days here in Baveno. Could you help me starting off with some definitions on pharmacokinetic, so just to give me some advice as a urologist or medical oncologist, what the definitions are?
Okay. Yes, Axel. Well, considering that most of the drugs are given by oral route, the first problem is the drug interaction at the level of absorption. We used to give to patients proton pump inhibitors to protect the stomach from oversecretion, and this is the first point of interaction because many proton pump inhibitors can reduce the absorption or modify the absorption of orally administered drugs. And the second level of interaction is at the absorption at the intestine level because, for instance, food can interact with the absorption of drugs, and also drugs like iron or antacids can interact with the absorption of many drugs. So also at that level, we should be aware that drug interaction can reduce the absorption and reduce the amount of drug delivered to the disease. And the third level of interaction is, of course, at the liver level. In the liver, a drug can be metabolized, and metabolites are delivered to the bile route in order to be excreted by the intestine or released back to the blood, and at that level can be cleared by kidney. So if we administer 2 or more drugs together, we can have an interaction on drug metabolism system, and also on the proton pump inhibitors can also affect the drug metabolism. So we have many different steps in which you can have a substantial difference in drug concentrations due to drug interaction again.
Thank you. So when it comes to daily clinical practice, Romano, what is your advice for the novel substances? We have a lot. We have enzalutamide, we have abiraterone, we have radium-223, we have still docetaxel, carboxytaxel, and all those novel substances really delivering overall survival benefit and therefore are very important within the treatment armamentarium of deadly prostate cancer. So what is your advice? Should we consult you more often as experts, or your department, the colleagues from the department as experts on how to treat, or can we still continue to treat ourselves? Or what is, for example, your caution for enzalutamide, abiraterone, or what should be taken care of the most?
Okay. Well, I think the best approach is to collaborate and to interact each other, because there are many interactions, that for sure. The problem is to select which interaction is clinically relevant for the patient. So the basic idea is that for complex diseases and for chronic treatments, the interaction between the clinician and the pharmacologist is important in order to improve our ability to deliver the best treatment. In terms of novel drugs and metabolic profile of each drug, we know from the literature that, for instance, enzalutamide is released by the kidney up to 70% of the dose administered to the patient, while abiraterone is eliminated by the liver up to 70%. So these two drugs are very different in terms of elimination, and this could be important for the single patient in which you have reduction of kidney activity, kidney clearance or function, and the same for enzalutamide or abiraterone towards the liver activity of elimination. So that's the first point. So there are these two drugs are very different, and also they are very different in terms of metabolism, because in particular enzalutamide is metabolized by different enzymes in the liver, and also can induce the activity of selected enzymes and inhibit other enzymes. So the profile is complex, and the clinician should be aware of these potential drug interactions, and collaboration and exchange of ideas and suggestion is very important.
Okay, so we have to work on our education in this field. I also had this impression while being here at this excellent meeting, and when looking at the patients, the men with CRPC, most of them like to drink a glass of wine or a beer for good dinner. So how does this daily, for example, alcohol input affect those novel treatment options? Does it have an effect? Do we have to advise our patients on how much alcohol intake? Because this is a question that often comes from the patient. Doctor, my wife told me I cannot eat red meat anymore. No alcohol, no cigarettes. So from your standpoint, how should we advise our patients?
Okay. Well, it is always very good to avoid cigarettes. Of course,
yes, I agree. As a urologist, truly agree.
And particularly smoke is a strong inducer of liver metabolism. And but concerning the alcohol intake, at low doses, the alcohol intake is a modest inducer of enzyme drug metabolism. So
that means, if I can interrupt you there, that means the drug works more active?
Well, it depends, because we have some drugs that are pro-drugs. So if you induce metabolism, you increase the amount of active drug delivered into the circulation.
So for the specific drugs, abiraterone, enzalutamide, a glass of wine in the evening, what does it do?
Okay.
Sorry to pinpoint you there.
Yes, that's a good point. Theoretically, since abiraterone needs to be metabolized to reach the activity, because it's abiraterone acetate, and acetate should be removed by esterases. So if you increase metabolism, you increase the activity of the drug, because it is converted to the active moiety. On the contrary, enzalutamide, when metabolized, gives to a number of inactive metabolites. So the increase in enzalutamide metabolism can reduce potentially, but of course it should be proven in the clinic, but potentially can reduce the activity of the drug.
So Romano, thank you very much for your insight, your update, your education. I've learned a lot here with you at eCancer. Thank you very much. Thank you for listening to us, and have a good day.
Thank you.